Good afternoon to all. This is our last session, end of healthcare and medical ethics. This session will be taken by Dr. Arjun D, who is a palliative physician and having more than 5 years of experience in palliative care. And he is heading our medical service, the team. And he is in charge of the clinical service.
Thank you, Sister Shiva. Good afternoon, everyone. I'm Dr. Arjun. Today we will start a session on ethics and end-of-life care. So before we start about ethics and end-of-life care, let's discuss about this in brief about a transition in chronic illnesses. So in chronic illness, in the early stage, we get the patient diagnosed. After that is general condition. So there are changes in his body. Disease containment, the function may be maintaining in its initial stage, but as time goes, decompensation sets in, and he starts experiencing the symptoms. And he may become, he used to be doing his own things himself, may start to get depending on others, and symptoms may be getting worse. And by the time, as time advances, the decline and terminally ill, and then ends up in death and bereavement. So when does palliative care start? So when does a patient with a chronic illness come to you? When can we start palliative care? At the time of diagnosis. Thank you. So once we have a diagnosis, we can start the palliative care. So you can see in the figure, once diagnosis has been made in the early stage of the disease, we can start palliative care. And as time goes, palliative care does continue through, we travel through with the patient and does not end with the death of the patient. We continue with the bereavement support for the family also. Okay. So coming to ethics, we have 4 cardinal principles of ethics. Ethics is important. Ethics is important in everyday practice for us. So every patient we are seeing, any action we take, whether it's a medication or any procedure that we advise, we have to make the decision depending on our ethics, considering the 4 cardinal principles of ethics. First is autonomy. Autonomy means the patient decides for himself. N word is patience, and the patient has the right to make decision on himself. The second most important cardinal principle is beneficence, that is always do good for the patient. Any intervention or a change that we do for him, intended for making it good for him. And maleficence, for non-maleficence, whatever we are doing should not be harming the patient. And the fourth one is justice, that is equitable distribution of resources. All these cardinal principles are having equal weighting in every case. So have you ever thought of your own death? Have any of you thought about your own death? Yes, no, don't want to?
We just wanted to see the faces of all. Kindly keep your videos on. Otherwise, we should think that we are not there. The blank screen is there. Please turn on your cameras, at least for a moment.
Please put your answer in the chat box.
So in any point of your life, have you ever thought about your life and death? Yes, yes. Okay. Anybody without a no, no, or I don't want to? So now those of you, let me ask, which one would you think would be a better way to go your end of life? In first picture, you can see a lady who is in her end of life. She's at her home and she's being fed by her daughter. She and on the second picture, you can see someone who is in an intensive care unit with a number of tubes coming out of his body. He's alone. He's being taken care of a clinical team. He's getting a good care. Both of them are getting good care. So which of the two do you think is a better way to go? Sandbox. Everyone thinks first way is the better one in the presence of the family. Anyone with an option that second one is the best one? Okay, thank you. So everyone thinks it's first. So now we will discuss about something. So we have a 78-year-old female. She was diagnosed with carcinoma lung. She already had some form of hypertension, diabetes. So she was brought to you for your care. She is catatonic, very weak. She's bedbound and dependent on all activities of her daily life for on her loved ones. She was brought to you for that complaining that her son or daughter brought you. Okay, her son brought to you, say that she's not taking anything oral. She's very difficult to feed. And when you examine her, you find out that he has aspiration pneumonia and end-stage renal disease. So the doctor who's also advised antibiotics and dialysis, which the patient refuses, but the son wants her to undergo dialysis and NG tube insertion so that they are able to feed her and they'll be happy that she's having some food for them. So she is advanced stage of carcinoma, end-stage renal disease, aspiration pneumonia, cathetic, bedbound, dependent on all activities of her daily living on others. And she is here. The son wants to undergo put her on dialysis and NG tube insertion. So what will you do? Will you advise the first patient and we let her, we'll talk her and force her to put an NG tube, antibiotics and dialysis. Remember, she has an aspiration pneumonia, so that calls for an antibiotic. She has an end-stage renal disease that does maybe needing a dialysis, and she's not taking orally. So, will you talk to the patient, make us or force her into all these decisions you made? I'm not seeing any answers. What if the patient was brought to you and it's your decision to do that? Anupama madam. So what do you think? If you are on the state, what will you advise? Will you advise?
Yes,
So,
advise
pardon?
advise the patient and also his son about the need of NG2 insertion, antibiotic and dialysis.
Okay. So is there anyone who with another opinion? Anupama madam suggested the patient will benefit from NG tube, antibiotics and dialysis. So anyone with another opinion? So Karolshika has informed that we will explain her the need for NG and dialysis, but not for her. We'll ask her for cooperation. Okay, good. Anyone with any other opinion? In case a patient to take antibiotics and NG tube. Yeah, that's what I'm. Okay, next section. So what we see, so in the early years, okay, sorry, Mr. Oya Casmeros, if we follow the patient and explain to the family the comfort measures instead of aggressive management like dialysis. Okay. So what we see in the case of she was saying she doesn't want to undergo this dialysis and antibiotics. So will you avoid talking to her and discuss a treatment with the relatives alone? The family wants to go with what you have decided or you advise. So will you stop talking to her? Anyway, she is bedbound, she doesn't have much, or she has already lost her position in the family. Voice. And the sons are taking care of her, she is dependent on them. So their decision may be the one that lasts. So will you avoid talking to her and discuss a treatment with her? What do you think, Mr. Oya Casimiro? What would you do? No, it should be to discuss the patient. It should be discussed. Did you mean that you won't do that?
Yes, hello, sir. Hello, can you hear me?
Yes, please.
Am I audible, sir?
Yes, you're audible.
I think, sir, it's better to discuss the treatment plan to the patient and to the family by means of doing family meeting together with the member of the family to explain further what is the treatment that the patient must need during that during the illness.
Okay, thank you. So, but the question here is, will you discuss with the patient relatives alone? If the patient has objected, and will you discuss with the patient alone? Correct, relatives alone. Next thing is, will you respect the patient's wishes? No. Or that you find that you are in dilemma what to do, and you will refer to a higher sin. See, let's see the case. So this lady, the poor lady, is suffering from very advanced carcinoma lung, hypertension, diabetes, she has multiple. She is very chaotic, being bedbound and dependent on all activities of life. She might be having severe symptoms which may be on medication, control or uncontrolled. And she has aspiration pneumonia, end-stage renal disease. So one thing we can see is she's nearing the end of life. She's had very advanced disease. Her general condition is deteriorated. Aspiration pneumonia asks for an antibiotic session, and end-stage renal disease asks for definitely a dialysis, and can on decrease oral intake, a condition that worsen. But the question is, the patient has refused. So this is a first cardinal principle of ethics geriatrics, the autonomy. The patient decides. The patient is the decides on the last one. Definitely, you have to explain to the patient about both sides. What is needed, that she is asking aspiration pneumonia, it means antibiotics or dialysis, what you expect. You have to explain her what both sides can end up to. If she goes through that way, or if she doesn't want to, and still she doesn't want to do that, we will have to respect her decision, because it's our body, it's her life, and she's the one to decide. The family may not be knowing about the condition that she has to face. For them, they might be want to do something to make a mother comfortable. So they might be feeling a guilt that if they doesn't go for this advanced treatment, are they putting their mother to more distress? The family may be thinking out of love, but they may not be knowing this. See, the primary objective of end-of-life care is to mitigate suffering. It is to cure sometimes, live often, and to comfort always. There is no exception for this rule. This came up in the ICMR a few years ago. So it's always to mitigate the suffering. So in ethical decision making, so who makes the decisions on the patient's condition? The doctor, the clinical team, the patient, the family. Always we have, when we are taking into consideration, we have to look at the expectation, what they expect from this, and what is the socio-cultural context of the family also. So in end of the day, it's a patient decision, but we have to take something, other things into consideration. Is the patient able to understand the situation? When I explain to the patient about the condition, whether about the aspiration pneumonia, is she in a state to understand that what is aspiration pneumonia and what are the endpoints of this? Is she able to appreciate the choices available? She has two options, and is she able to understand each option separately? And ability to reason the benefits and burdens of the treatment. Are they able to rationalize? And are they able to communicate the goals and their wishes to us? So when we are talking to the patient, we have to look into this. So autonomy is kind of a relationship depending on the relationship with our relationship with the patient. Always have a respect for the patient's privacy and confidentiality. Empathetic truth telling is we always have to be honest to the family, patient and the family. Don't give them unrealistic hopes. Always talk to them in private. Even if you have a doubt in something that the patient has asked, open them truly. That you don't know about this clearly, but I can refer to you or ask my seniors and come back to you. Just because you don't know, you don't have to lie to them. Always give them what the truth is. Always give them informed choices. So whatever the choice you are giving, it should be well informed. So if you are giving both options, what happens if you go with antibiotics? So and what happens if you go without antibiotics? So all the choices has to be given and fully informed. What comes out of it has to be informed. So the decision making should be shared, making aligned to the patient's culture and religious beliefs. All decision, if what we discussed earlier, even though the doctor, the family, the clinical team, and the patient come together in the decision making, everything has to be, it's ideally to be a shared decision, but end of the day, patient's decision is final, but we can give our opinion. Collective, in Western countries, we can see that the patient is the one who gets to the doctor first and the one to know the diagnosis initially. Only after that, with their consent, the family comes to know. But coming to our culture, it will be usually the family will be coming to us, initially asking for the condition. And thus our culture means that families input has an important role in the patient's continuation of care. So ideally, a collective autonomy is a norm in our culture. So we'll have to involve the family also in the decision making. So their opinion should be considered. So regarding informed consents, so whenever you are giving an informed consent, try to give it them in a simple language that they understand each and every point of view. So you can see in the picture, the doctor is giving a large number, a very confusing theory on that there are alternative therapies, benefits, harms, and the patient is confused. They are not able to take a decision for them. This is not an informed thing. When we explain to them in the simple words, so they can understand and we find that they understand and they can make a decision on themselves, that would be the ideal informed consent. See, this conversation should be between the experts. We are experts on healthcare. We know what's best for the patient's treatment. We know what that this medication can help you in this condition. But the patient is the expert on his own life. That's we are not the expert on him. He is the expert on himself. So the decision making, the conversation should be happening between the experts. The patient has the right to know. We should discuss with the patient. So what if the patient has very dementia, an advanced dementia, and doesn't have a ability to take a decision for himself? What can we do? Okay, so who can answer this question? Madam Nancy Joseph, can you answer this question? Madam Nancy, can you answer this? And Nancy Joseph, could you answer this? Help us with this.
Sir, can you, sir, ഒന്നുകൂടെ ചോദിക്കാവോ question?
Okay. നമ്മൾ നേരത്തെ patient we have seen earlier. So she came to you. She's in this. A carcinoma lung patient is brought to you. She is very much cathetic, bedbound, and dependent on activities of daily life. You found she has aspiration pneumonia and end-stage renal disease. You want her to be on antibiotics and dialysis. Admit her and put on antibiotic and dialysis. Unfortunately, the patient, so we came through that the patient has to make the decision on the treatment. But unfortunately, here she is having severe dementia and is not able to take a decision for herself. What can we do for her?
And you can discuss with the caretaker.
Exactly. Thank you. So there, a surrogate decision maker we can depend on a surrogate decision maker. So, and if the patient is not able to take an informed decision or not able to make out the choices they have, then we can depend on a surrogate decision maker. The next of kin is ideally and legally the person for decision making. Sometimes in some cases, we can see there are nominated persons. They might have already made a decision that he is the one to take a decision on their life when they become unable to respond. There could be some or any other legal guardians. So in case of children, sometimes a guardian may be there. But the thing is, it has to be a reasonable one. And the interest of this caregiver should be lying with the best interest of what the patient wants. This has to, so that's one point that we have to look into when we depend on a surrogate. Always look for advance directives. Is there a living will? If the patient has already made a living will, that when something, so you know what happens in chronic diseases, we might be already have discussed with them, and they might be knowing what is going to happen in the future. And some might make a precautionary writing will, and which is known as an advance directive, that if something happens in a stage that I cannot make a decision for myself, this person can take a decision. So DNR, have you heard of DNR, the do not trust state? So such things comes under advance. Sometimes a patient have a DNR request that if they doesn't want to go for a do not trust state, they doesn't want to risk it if the heart stops. And if they're a living will on that, yes, we can use that to make the decision on the patients. So the second one, beneficence. What we want to do is whatever we do should be in good terms for the patient. So here the relationship is with the outcome of whatever the procedure or intervention we are planning to do. We have an obligation to act in the best interest of the patient. What we want, whatever we are doing, should end up with a good result for the patient. We have to ask some questions when we are doing something. So suppose if I am starting a new drug for him, a patient, I will have to ask myself, am I trying to fix what is wrong with the patient? Am I effectively managing this disease process? So what is the burden with the benefit of the treatment? So I start a tablet that costs 20,000 for like 1 lakh. Propose. I start a chemotherapy for an advanced cancer patient. One injection for that is 1 lakh. So it's definitely going to put the family in a very big burden. And if we take this injection for this patient, what will be the outcome that we can expect? The benefit of the treatment has to be outweighed with the burden. So if I start this, is the patient going to benefit from it? Then I can go for that. But if it is going to be a burden with less benefits and more burdens and less benefits, definitely that I have to rethink myself. What is a risk? Is there any risk for this? Is the suffering and pain will the intervention cause? If I start this medication, will his suffering increase? Will he be in more trouble? Am I delaying the inevitable? So am I in, is this, I'm just trying to delay the death, not looking into his comfort. Am I just trying to delay the death of the patient? So what is the expected prognosis with or without the treatment? So if I do this chemotherapy, will this prognosis improve? Or does it not? If it does not, what is the point of giving this medication? So whatever I am going to do, it should be for the good of the patient. We have a 20-year-old boy with an metastatic osteosarcoma for the lower end of femur. He is already diagnosed with lung metastasis and severe anemia. He has a large tumor on his thigh and the family wants to get it operated. Both the parents and the patient is adamant regarding the operation. You are the surgeon or you are the health member of the healthcare team to take the decision. You the one to give a go or no go for the surgery. So what would you do in this situation? Very advanced carcinoma. There is a severe lung mets, severe anemia. There's a large tumor on his thigh. The family and the patient the patient also wants to get it done. You are the one to take decision. What will you do? Will you give a go or no go for the surgery? Madam Liana, what if the choice is up to you to give a go or no go? What will you decide?
Yeah, I was typing my answer. Let me read it. I would say to first educate the patient and the family, make sure they understand the risks versus benefits. And if the patient still wants the procedure, the surgeon will have to listen to him, especially because he's close to being an adult. However, if it's like life-threatening, I'm not sure if the surgeon needs to act on that.
Anyone with any other opinion? Thank you, Liana, for the update. So, input. So this is a surgery. It's to be done on a very advanced carcinoma stage. So when it comes to autonomy, the patient wants to go for the treatment. Yes, definitely you have already, as Dr. Liana has informed, we can discuss with them about the outcomes, possible outcomes and conditions. And still, if they are adamant, will we do the surgery? Here, we have to go for the other ethical principles. Right. We have rolled out autonomy, beneficence. Is it going to do any good for him? Is removing this mass any beneficial for him? He might have some belief with the aesthetic belief will be there. But isn't it going to be a more harmful thing? Very advanced lung mets, very lung mets and very severe anemia. So such a person to go for a surgery, such a major surgery at this stage of life will be very debilitating for him. So he has to go through the post-op period, the pain, risk of infection, hospitalization, the cost. Are we going to benefit from this? That's the question you have to ask. And this might be more harmful for him. So this is the principle that we have coming to discussion next. Malefactions. Do no harm. We respect sanctity of life. So this here is a right of a physician. We have the right to decide on this. Non-malefactions always our rights autonomy. We can do that. See here, in this situation, we can outweigh the benefit versus the harm. So this surgery, what are the benefits of the surgery? The benefits. So it could be the debulking. This mass can be reduced. That's aesthetically there is an improvement. Psychologically, they will feel some benefits are there. But when it goes to the harms, there is severe anemia. The patient has to go for a general anesthesia, the post-op complications, in risk of infection, ICU admission, the duration of stay in the hospital, financial burden, the amount of stress the family has to go through, the pain. When we are weighing these two, the harm is going down. So the harm part of you can see the thing. So when the harm part is going down, so it's more overburden. So here, how we come to a decision that this surgery is going to be more harmful for him. So we have the right to say that we can't do that. So this is the importance of the malefactions. Demand for a specific medical therapy that is devoid of a clinical evidence in the given clinical situation. Request from family to withhold their medical information. That is another thing where malefactions. Conflict of opinion among family, conflict of opinion among healthcare providers. All these there, we can make malefactions an important point of decision making. So this is an important part, doctrine of double effect. So a person coming to you, so you could be in a cath setup, that a person, a female young lady has been brought to you with an ectopic pregnancy in a fallopian tube. She's taken up for surgery. Your team did an removal of the fallopian tube because it has been burst. So this surgery, you did it for saving a life, but it has two effects. A good effect that you want to save a life, a bad effect that it's going to affect your fertility. So both effects are there. You did an intervention, has both effects, a good one and a bad one. Is it wrong to perform a salpingectomy in this stage? You're harming her future life of your fertility stage, but you did an intervention to say this to save her life. So this is an example for a doctrine of double effect. It is a single act having two possible chain effects, one good and harmful. This is not morally prohibited if the harmful effect is not intended. So considering to this lady, our aim was to save the life of the lady, not to affect her, but affecting her fertility or futures was an unavoidable thing. But we know both, but we outweigh the good. Our intention was to do good for her, to save her life. So this is not morally prohibited. The same thing can apply in several conditions. A patient with severe breathlessness, an end-stage breathlessness patient is coming very distressed. What we do is usually administer midazolam to make her calmful, the patient calm and settle. We know midazolam can cause respiratory depression. So that's a bad effect we will have from the patient medication. But the good effect is the patient will get calm. So we are doing intervention, we are giving one medicine, it has two adverse effects, one good and one bad. But our aim is good one. We want to make the patient comfortable. So this administering midazolam at end-stage disease is not morally tolerated. This is where the doctrine of double effect takes place. One thing is the action must be morally good. You must not desire the negative effect. We know the negative effect is going to happen, but our aim is to do good for the patient. And the good effect must be as immediate as a negative effect. Both should come to that when the negative effect takes place, the good effect also should complete. So we have another patient, a 57-year-old man with advanced carcinoma of lung. There is severe weaknesses due to progressive disease. All reversible causes of disease have been rolled out, and he is brought to you to get admitted to the ICU for anti-infection ventilation. What do you think about the decision? Madam Suman, what do you think you would do if you are the one to take decision? If you are the one to decide whether the patient should go to ICU? Okay, anybody else? Madam Diana?
Diana, are you there?
Yes, ma'am.
Yeah.
So what do you think about the decision that the patient is to be admitted to for artificial ventilation?
Sorry, sir, I don't know.
Okay. Anyone else? So Diana, okay, yes, you are in a stage where you cannot take a decision. So this is a bit, are you there?
Yes, sir.
Okay, so let's go through these principles. So we went through the 4 principles. So autonomy. Okay, let's roll out. The patient is okay with whatever you're doing. It's unable to take a decision, and the family wants to get him treated. So you roll out autonomy. Beneficence. Is it going to do any good for him? What do you think? An end-stage metastatic carcinoma patient. He's in severe breathlessness. You, the one who saw him initially, has rolled out all other cause of breathlessness. This can be managed. The only thing left for is like we can put him on artificial ventilation. We can ventilate him, and they suggested ventilation. So, do you think this ventilation is going to do any good for him?
Diana, what do you think?
Yes, sir, it's good for him. It's good for his health. I think that.
Okay, you believe it's artificial ventilation will help him.
Yes, sir.
Anyone else with another opinion? So artificial ventilation will help us to maintain, prolong his death, but his quality of life is something that we have to think about it. Is the ventilation going to help him? So his breathless not because he's not able to, his breathing center is affected in the brain or his muscles are paralyzed. It is due to the progressive carcinoma. So artificial ventilation may not be helpful for him. So it is not going to do any good for him. Is it going to be harmful for him? What about non-malefficients? So this is a place where palliative care can act. We can help with the help of medications. We may be able to control his blood pressures and to a stage that at least even with the help of continuous infusion or something, we may be able to help him. And he can spend the rest of his time with his family on his bedside. There is no point in ventilating him at this stage. So this might affect his quality of life for the rest of his time. So in this situation, we have gone through all the three cardinal principles of ethics: autonomy, beneficence, and maleficence. So there is one more thing that we forgot, that was the justice. Suppose you are in a hospital with 3 ventilators. 2 of them has been already occupied, and you have 1 vacant bed there, ventilator there. So this patient comes, and another patient. So he's a young patient. So this patient is a 57-year-old man with end-stage carcinoma lung, with very less output benefit in being ventilated. But yes, the situation, as Diana has informed, requires an artificial ventilation. He might be helpful. But another young patient from a road traffic accident came to you. He was also needing ventilation, but you only have ventilator for him. Which patient will you suggest? The young patient or this man? Both of them came at the same time, and you are the one to take a decision. If Shiny Madam is the one to take a decision, what will you do? Which one will you send into the ICU? The young patient or the old one?
She's muted.
You're mute. Can you unmute yourself? You're still muted. We can't hear you. Now you are audible. Sorry, we couldn't make it. Can you repeat yours? Are you there, Shiny Madam?
Can you hear me?
Yes, you are audible now. And some disturbance are there. So whom will you send to the ICU? You have 1 ventilator left. So Mr. Oyo.
It's the correct decision. It's the correct decision.
Which is the
Hello?
correct decision?
The young one.
Young one. Why do you think the young one would be better? See, the other man is also on severe distress. He also needs a ventilator. This old man. Why do you think? Why will you prefer the young man over the other? I think we lost her. Mr. Oyo, what do you think? Whom will you send? So, Carol said that if the prognosis of the young patient is predicted to be better. No, we don't have any prediction. We don't know what the prognosis will be both of them. So both of them, we don't know. So we have two case scenarios. Whom will we give for the ventilator? So everyone says the young patient. You all will prefer young patient over the other. So I will agree to the answers. So here comes the fourth cardinal principle, the justice. So here we know healthcare is a very scarce resource. We want equitable access to all resource to everyone. So when you take this consideration, so Mr. All patient with the advanced carcinoma, so we are sure about that he might not benefit from that. We have come to a conclusion already. It is going to more harm for him. But when we take into a young patient, he's very young. He came from after an RTA. He might better. So he should be given more access to ventilator as per your. So are we allocating the precious resource of the ICU justly? That's the one you answered. Are we considering the family resources? So when we put a patient in an advanced treatment, like a chemotherapy or as we said, ventilation therapy, the family resources has also to be considered. The family psychosocial issues, are they able to afford them? Is this treatment going to put the family into streets? Are they going to have to send all their gold or all their valuables to be sold or put into loans? So our decision has a role in their family result. So studies say that about 1 to 12% of all healthcare expenditures are consumed by the end of life care. So we have a duty to individual patient and society as a whole, which may conflict in cases in which limited resources are disproportionately consumed by a critically individual. Here, the assessing the futility, whether is beneficial or is it a useless move, becomes very important. Your decision whether this action you are going to do, if it's going to be futile or useless, becomes very important in this such situation. We want a fair allocation of what the resources are available to everyone. So when we come to futility, so it's an aggressive or excessive medical interventions in terms of efforts required and financial resources utilized, having little or no clinical outcome. So which are those futile interventions? Those which does not slow the disease progression. Those will not sustain life or reduce the disability, or they have any in a change in the health or discomfort of the patient. For the old man, the ventilation is not going to slow the disease progression. It might not sustain his life. It does not reduce the disability. It is going to worsen his disability, and it is not going to improve health or discomfort. It might definitely have to discomfort. So that might not be helpful for you. So when there are situations that we ask ourselves whether discontinuing this treatment, like sustaining treatment, is treatments that does not provide net benefit to the patient may ethically and legally be withheld or withdrawn. It's legal because if it does not provide any benefit to the patient. Our medicines, so goal of this is these cases can be shifted to palliation of symptoms, getting him comfortable. If we cannot benefit from the intervention, there is no ethical difference between withholding or withdrawing. Euthanasia is an important topic that comes to discussion all over. So it means that intentional act of ending patient's life by medical means at the request of patient or family with an objective to end or avoid suffering. So you find the patient is going to severe suffering and nothing more can be done, and the family asks to end his life. We act intentionally by medical means so that his suffering comes to end. So there was some legal documentation says that it's a passive method, but euthanasia is not passive. It's a deliberate action that we do. And it's illegal in India, but legal in some countries in Western states, in Europe, European countries where people often travel to get a peaceful death there. So please mind withholding and withdrawing life support in a patient with terminal illness nearing end of life where it is not going to be a benefit for them is not euthanasia. Euthanasia is a deliberate act that we do by medical means to end the life. So certain recent Supreme Court judgments, the right to die with dignity is a fundamental right as already declared by the constitutional judgment of the court. You have, every Indian citizen has the right to die with the dignity. We declare that an adult human being having mental capacity to take informed decision has a right to refuse medical treatment, including withdrawal from life-saving system. A sound-minded adult has the right to take his decision on this treatment, even if it's some withdrawal from life-saving devices. An adult human being of conscious mind is fully entitled to refuse medical treatment or decide not to take medical treatment and may decide to embrace death in a natural. It's all up to the patient. An advanced medical directive or living well is an individual's advanced exercise of his autonomy on the subject of extent of medical intervention. Like if they have comes to a stage that they cannot make a decision for themselves, he can already put up an advanced medical directive when he is in sound of mind. So that all his wishes come taken upon his body at a future date, which when he may not be able to say for himself. Living will is a legal document. It's created by the patient. So explaining and documenting the wishes about medical treatment if they become incompetent and unable to communicate during a terminal illness. This will be a helping guide for medical professionals like us to take a decision on and the family about this care, continuing of care. Always be truthful to your patient and be honest. Always go for informed consent and always tell the truth. Communicate what you do. Make sure that communicate what you document and always document what you communicate. So even in legal issues, a proper documentation can help you. Give only realistic treatment options. Allow the time. Continue existing measures. Sometimes when you go for them, tell them about these situations, but a decision making has to be done. The family may be confused. Give them time, enough time, but we have to be cautious. the patient is in, give them necessary time and continue the existing measures for the time being. Accept decisions for partial support. We go on improvising in further visits or further talkings. Avoid reinforcing sense of guilt in the family. So this is something we very commonly see. Any action that we might be saying about that might, if we suggest to hospital futile treatment, that might induce a feeling of guilt in the family, or someone else will come to tell them, and you didn't give proper treatment for them. So we have to inform them that this is beneficial for them. Never say there is nothing more to be done. Explain that care will continue to be available. We have things to do. There might be nothing more to do for the disease, but we have more to do for the patient. We still can make this symptoms control. That is where the palliative care works. So as Basilius says, this physician said, the most fundamental principle of medicine is love. Love your patient, always respect your patient. So just think, one day we might be the one sitting on the patient's side, and treat the person sitting in front of you as someone you would like to be treated. How? Thank you.
Thank you, Dr. Arjun, for the wonderful presentation. Anybody have any doubts on this topic, please ask.
Sir, Nancy. Sir, മലയാളത്തിൽ ചോദിച്ചോട്ടെ? സാർ, നമ്മൾ ആ യങ് പേഷ്യന്റിനെയും ഒരു ഓൾഡ് പേഷ്യന്റിനെയും ഐസിയുലേക്ക് ബ്രെത്ത്ലെസ്നെസ് ആയിട്ട് ഷിഫ്റ്റ് ചെയ്യുന്ന കാര്യം പറഞ്ഞില്ലായിരുന്നോ? അതിന്റെ റീസൺ ഒന്നുകൂടി ഒന്ന് പറഞ്ഞു തരുമോ?
നമുക്ക് ഒരു വെന്റിലേറ്റർ ബാക്കിയുള്ളൂ. ഈ ആൾക്ക് രണ്ടുപേരുടെയും നോക്കുമ്പോൾ, ഒരു പ്രായമുള്ള അഡ്വാൻസ് ക്യാൻസർ ഉള്ള ഒരു പേഷ്യന്റിന് ആ വെന്റിലേറ്റർ കൊണ്ട് ഉപയോഗം ഉണ്ടാവുമോ? പക്ഷെ യങ് ആയിട്ടുള്ള ഒരു പേഷ്യന്റ് ട്രാഫിക് ആക്സിഡന്റ് ആയിട്ട് വന്നതാണ്, ആൾക്ക് ബെനിഫിഷ്യൽ ഉണ്ടാവാനുള്ള ചാൻസ് ഇല്ലേ? അപ്പോ ഇതിൽ രണ്ടുപേരും നോക്കുമ്പോൾ ഈക്വലി ഇമ്പോർട്ടന്റ് ആണ്. പക്ഷെ ആർക്കായിരിക്കും ഈ റിസോഴ്സ്, നമ്മുടെ കയ്യിലുള്ള ഒരു വെന്റിലേറ്റർ ഇതിൽ ആർക്ക് കൊടുത്താലായിരിക്കും ബെറ്റർ റിസൾട്ട് നമുക്ക് എക്സ്പെക്ട് ചെയ്യാൻ പറ്റുക? യങ്. അതുകൊണ്ട് നമുക്ക് ആ ഒരു ഇതിൽ സജസ്റ്റ് ചെയ്യും. ഇത് കേസ് അനുസരിച്ച് മാറും, സിറ്റുവേഷൻസ് മാറും. പക്ഷെ ഇങ്ങനെ ഒരു സിറ്റുവേഷനിൽ അതായിരിക്കും നല്ല ഡിസിഷൻ എന്നാണ് തോന്നുന്നത്. ഇതാണ് നമുക്ക് കയ്യിലുള്ള റിസോഴ്സ്. ഇതിപ്പോ ഈ റിസോഴ്സ് എങ്ങനെ കൊടുത്താൽ ബെനിഫിറ്റ് ആവും? കാരണം രണ്ടുപേരും ഈക്വലി ഇമ്പോർട്ടന്റ് ആണ്, പക്ഷെ ആർക്ക് കൊടുത്താലായിരിക്കും ഔട്ട്പുട്ട് നന്നായിട്ടിരിക്കും. അതാണ് ജസ്റ്റിസ് എന്ന് പറയുന്നത്.
Okay, thank you, sir.
You can unmute yourself, Sean. You wanted to say something?
Okay, so if you have no questions, we can move on to the case presentation part. In the meantime, if you have any questions, please put that questions in the chat box. After that, we will discuss. Carol?
Ma'am, can you hear me?
Yes, yes.
Good afternoon, everyone. I'm Carol, staff nurse at Lendore Community Hospital. So my case presentation will be on metastatic CA cervix. So this case is from March 2022, that is this year only. While I was working in the previous unit that I was there. Recently, I'm in Lendore. So the previous unit that I was working, the case is from there. So this was a 49-year-old female who came with the diagnosis was metastatic CA cervix. Presenting complaints was she had high-grade intermittent fever, painful micturition and decreased frequency of micturition. Later on, she had hematuria also along with it. The history of illness was Mrs. X was diagnosed with CA cervix in May 2022. She underwent 5 cycles of chemo, and a surgery was also done on the August 2022. She had finished radiation therapy and surgical management and in October 2022, and was declared cancer-free by November with various tests and scans for confirmation. Then she came to ED with the above mentioned complaint on March 2022. On examination, heart rate was 102. She was a little tachycardic, and respiratory rate was 24. BP was 130 by 80, and temperature was 101 by 2. So clinical examination gave a UTI as differential diagnosis, and she had bilateral hydroureteronephrosis also. And treatment was she had raised TLC and increased leukocytes and RBC in the blood routine that was done. USG showed a mask in the inguinal nodes, and it was confirmed with the biopsy that it was malignant for her. And later on, with scans and all, it was confirmed that the cancer had spread peritoneum. It had spread to the abdomen, everywhere else also. So she was on palliative care later on. And psychological aspect was that she's a mother of 2 young daughters. She has 2 young daughters. One was 13 and one was 8 years old. She's the only child to her parents, and she takes care of them. Her parents are also very old, and their treatment also she was taking care of. She worked in the same hospital as a cleaner, so most of her treatment was being taken care of by the hospital. She didn't have to pay for everything. It was taken care for her. All her money, but she's a cleaner, and she did not have much of a salary. So most of her money was going on her parents' medications and her children's education. She had a poor family background, and she was her main worry was that her husband might get married and like find another mother for her daughters, a stepmother, which might which might affect her daughter's future. Medications that she was on was meropenem TID, morphine 5 mg Q6 and injection morphine PRN as needed. And capsule tramadol was given 100 mg Q8 for her. Discussion points will be for her pain management, because she had severe micturition, burning micturition for her, and fever as she went into sepsis later on, and financial problems that she was facing.
Thank you, Carol, for the presentation. Anybody need any more clarification regarding his patient story? Please answer. Otherwise, we can discuss.
I just want to tell that this patient passed away later on after I came to this unit. So when I called up to find the details of the patient, the whole history, then I came to know that she already passed away. So I just wanted to tell that.
Okay, thank you. So how did you manage? This patient is having a lot of problems, psychosocial issues and all. So how did you manage? And we would like to hear from you all. So we learned palliative care, we learned how to assess psychosocial issues, how important it is, that all, how to communicate with them, how to break bad news, that all things we already learned. So this kind of patients comes to you with in your department. How will you manage? Anyway, the patient has died. We will discuss if these kind of patients, if you comes again, how will you manage? So please put your answers in the chat box, or you can unmute yourself and talk. Go back to the medication history. Medication. So do you think anything, any modification needed for this prescription?
Do you find anything that needs to be changed in this prescription? Nothing more. Look at the analgesics. Think about the WHO pain level.
Sunita, Vinita, Praisi, Saraswati, Evangeline, Kanchan Dinja, are you there? Please answer this question. Karan, what do you think?
Ma'am, actually, in the prescription I've written the medications that I know, morphine and tramadol was not given together. Initially, they started on tramadol, and then when the pain was not settled, she was on morphine, PRN injection, and morphine tablet alone, not tramadol along with it. Tramadol was only initially, ma'am.
Okay.
Okay, thank you for the clarity. Tramadol comes as a weak opioid and a step 2 analgesics. And usually we don't go with the step 3 analysis and step 2 together because both these may increase the risk of toxic symptoms. So when we switch, when we find the patient is having no relief with a step 2 opioid, we can stop the medication and switch to a higher opioids. We don't want the patient to have toxic symptoms, so that should be done. Here also the morphine isn't at 6,000 liters. Is there some reason why the dose was reduced?
I'm sorry, sir. I'm unaware of the reason for the dosage. Sorry.
What is the normal dosage that you will start for an opioid naive patient? She's not opioid naive. Okay.
5 to 10 mg. 5 to 10 mg.
Okay. How frequently you can give? The immediately tablets available have an action duration of action for early for near 4 hours. So we usually start with a 4-hourly dose. But in certain conditions, we will have a reduced dose, like a 6-hourly or 8-hourly dose. Can you say, point out a few cases where we offer a reduced dose of medication? At least one point, one most commonly seen. Your altered renal condition is one indication for a reduced dose. So what happens is if the kidney can't clear the morphine from the body, so the metabolites persist in the body and can lead to toxic symptoms. So if you find the patient's liver function, renal functions are altered, it's better to go for a lower dose. Another condition would be a very old person. There also we can look for a very weak patient. We can go for a lower dose of morphine. Okay, so what do you think? The patient has pain. So if you do a pain assessment for him, What are the pains, type of pains you have noticed for her? Definitely, you have noticed the physical pain. Do you see any social pain for her? What are the social pains? Anyone? Vinita? Vinita madam, can you hear me? So, Madam Liana, what do you think? Is she having any social pain?
Yes, I wrote it in the chat. I think she had a lot of stress about her two daughters that she would leave behind. And so I would suggest that before she passed, that she could have had a meeting with a social worker and her husband just to kind of calm those nerves, because that would be quite stressful.
Okay, I think that's more of a spiritual pain, let me comment. See, she's a fear of someone else taking care of her daughter. That's kind of more of a spiritual pain. Yes, then she's an only child to her parents. There is no one to take care of her parents. That's a social issue she's going. She's not able to work for family. She's not. She would be on treatment, so she would be losing her job. But I think she's been supported from the hospital, but still she's not able to be providing for her family. It was her salary that was providing for the parents' medication. So that's another social issue is going to. The family support, which husband may not be that supportive. All these can add to a social pain. Spiritual pains you have already mentioned, physical pain you have mentioned. So psychological pain definitely will be there. So you see that in a single patient, you have seen all phases of the pain. So just medications alone won't be helpful for her. We have to provide solution. We find any probable solutions to address all the phases of her pain, so that we can give her a good life, good quality of life. Regarding pain management, one more thing is always look for any correctable causes of pain. So one of the major pains that she mentioned was she had burning maturation and painful maturation. So the urinary tract infection could be the reason for that, which it could be corrected. She's in a corrective form. So if with that she's on meropenem, I think that would help her with that. What if the disease was very advanced and she is in bed bound, depending on others, and she's on sepsis? Will you go for antibiotics? So this is a situation you can ask for your ethical principles. Will antibiotic help her, do any good for her? It might cover symptoms. She's in the end of life, but she has a sepsis. This antibiotic may cure her urinary tract infection, but that is not going to improve the quality of life. So it might do good for him, but outcome is whether there is an improvement in quality of life. No. Is it going to do any harm for her? She needs an IV antibiotic. She needs to be admitted in the hospital again. More expenses. She has to be separated from her family. she may be put in an ICU or isolation ward. So she is looking back to the family. Then she has to go through all these costly medications. Marapanam is definitely costly one. And going through all the courses of medication that won't be at her pain. So this antibiotic might not help her in that stage. So we can take a decision, we can talk to her and we can inform her and they can take a decision that she doesn't want to go for the antibiotics if it is not going to benefit her. So these are situations where the ethical principles take into action. Anything else?
So if the patient is in end of life, here you can think about this patient. Anyway, the patient is died. If she is in the end of life care situation and the end of life stage, so what are the possible symptoms can occur? So these all things you have to keep it in mind. We all nurses, we are spending most of the time with the patients. As Dr. Arjun said, pain is one of the problem. So we have to identify the cause and try to manage that problem. So our main aim is to provide a comfort and give a symptomatic management. So we all know that. So even if the end of life care stage also, we have to think about that. As much as possible, we have to give a comfort. We have to provide a good comfort to the patient and the family. So we all always think about the family also, because they are going to lose their loved ones. So they will be in emotional status. Definitely we need to listen their worries, their concerns, and make them understand that. So because here the two daughters, they are going to lose their mother. So because we need to include their that children's, the daughters also in the patient's care, because they need to understand what is the condition of their mother, and so what was the treatment is going on. That all things you have to keep it in mind. And also the end of life care, the most common problem is death rattle. So death rattle is one of the most common problem. It will not be affecting the patients, but it will be affecting the family. So always you have to tell the patient about why the death rattle is coming. That the sound, because of the pooling of secretions in the throat, they are not able to swallow it properly. Because of that, the patient, when the patients breathe, the sounds produce. So they might be thinking that the patients will be in the breathlessness situation. So it will not be there. So you have to tell the caregivers. We need to give a reassurance to the patients, and also we have to give some we need to give support to the patient, because some non-pharmacological management can helpful for that conditions. We can provide a sidelining position to the patients, provide a good mouth care, and also reassurance. As I already said, you have to give some reassurance to the family members. And the next thing is usually the caregivers will be requesting you even if the last stage also, the caregivers will be requesting you to put a rice tube, and so they want to give food and fluids at the end of the stage also. So we all we need to understand one thing is food is a symbol of love. So always they will give something. So in our set life also, if someone comes to our house or maybe in your place, you will give something to eat. So we will express our love with giving some food items. So that's also in an end of life care situation also, they might be thinking like that. So if they request you to put some artificial hydration nutrition to the patients, definitely we need to respect their concerns, their emotions, all things we need to listen, because
they're requesting you to give the food and fluids to their loved ones. They are in the end of life stage, but they don't know whether that new artificial nutrition and hydration is not helpful for the patient. So that we need to educate them. If possible, you have to conduct a family meeting and convey the things. What are the benefit and the non-benefit, that disadvantages also. You have to advantages and disadvantages you have to convey with them, and then they will get an idea and they will understand. So these all things you have to keep it in mind when we take care of an end of life care patients. And also till death, after death also you have to continue your care, because they need a support. So bereavement support. We have to visit that patient. If possible, you have to visit the patient family and listen their psychosocial problems. And if they have a lot of problems there, definitely we give that counseling. And if the counseling is not helpful, then definitely you have to include a psychiatrist in that patient family's care. So definitely we have to keep it in mind. Patient as well as family is also important in palliative care. So our aim is to improve the quality of life of the patient and their family. Okay. Thank you.
Thank you all for joining us today. Thank you, Dr. Arjun, for the wonderful lecture. If you have anything to share about the total sessions, as this is our last session. So if you have any comments or recommendations, anything, go on. We have 5 minutes time, I think.
So we would like to hear from you. Your suggestion is very valuable for us. We need to improve our sessions. If you have any suggestions, please unmute yourself and talk, or you can put your suggestions in the chat box. Anybody want to say anything? You can. Anybody? Suggestions? No suggestions? So Nancy said first time attending this class. Okay. Thank you. Oyo, what do you think? Liana. Okay. So it was a great course. My suggestion that is for each survey after the class include an option to write comments. Okay.
We'll surely look into it, Liana, for the next batch on. And you will have an end evaluation. There you can also include your comment session. There's a comment session for you. So we will be having posters and end evaluation later, and your assignment 6 will be shared with you soon. so that you can express your thoughts, comments, everything there. Okay, then. Thank you all for joining us for the entire session. And we would like to hear from you shortly. The WhatsApp group will be there so that you can put your comments out there also. And you can use it for educational purpose also. So we won't be deleting that group. That group will be there. So thank you all for joining us. Shiva ma'am, thank you.
Yeah, so thank you all for that sessions you had attended this 18th session. And I hope you had an idea on palliative care now and how to take care of a patient, how to talk to the patients, how to convey breaking bad news to the patients, how much important for listening. That all things you learned already. Definitely you have to convey this palliative care knowledge with your colleagues, your friends, and all. You have to convey that among the medical professionals also, they don't know when will start it, when palliative care start and all. So who needs palliative care and all. So we are the persons to convey the message to the among our colleagues and medical professionals itself. So that's why we can improve that palliative care, maybe spread palliative care everywhere, and also try to include the